So many with endometriosis suffer from leg pain, groin pain, abdominal pain, and pelvic pain, and it's not always endometriosis. Join this fabulous webinar with Dr. Mark Zoland, Dr. Ahmed, and Dr. Amanda Olson, a pelvic physical therapist, to learn all about the generators of pain that can aggravate your groin, leg, and pelvis. This is a fabulous webinar, one of the ones we are most proud of each year, so stay tuned. Evening, Endo Summit Live, and welcome to this very informative webinar from the Endometriosis Summit on groin pain, leg pain, and pelvic pain. We have quite the team here for you today, starting with Dr. Amanda Olson, who is going to be part of our giveaway. She doesn't realize we're doing a giveaway. We're going to be giving away a set of dilators. We have a whole package from Intimate Rose, a set of dilators with the velvet rose. And also this is a great product, Enchanted Rose, which is the balm. So we have a whole package of stuff that we have from Intimate Rose tonight that we're going to give away to one lucky listener, and you must be present to win. Even better if you've bought your ticket to the Endometriosis Summit, which is available both virtually and in person. But welcome, Amanda. Do you want to introduce yourself to everybody?
Sure. I am a pelvic health physical therapist. I treat patients of all backgrounds and many different diagnoses, from incontinence to pelvic pain, and certainly love working with people that have endometriosis. I'm also the president and chief clinical officer at Intimate Rose, where I create fun pelvic health devices to help people manage their symptoms independently at home. And I teach on a wide variety of topics to other providers. And I also wrote a book called Restoring the Pelvic Floor for Women. It's a fun read. It's not as dry as it sounds.
Restoring the Pelvic Floor is actually in our book resource list on our website. So if you want to purchase that, you can do that. There is somebody else here who has written a book as well, which is on our list. Please welcome our resident groinecologist, Dr. Mark Zoland, who is a practicing general surgeon in New York City. Do you want to introduce yourself?
Sure. I am a general surgeon. I started out doing bread and butter general surgery for a while and got incredibly interested in groin pain, which then moved into, started with sports hernias and regular hernias, and then moved into any kind of groin and pelvic pain into the legs, anything that sort of morphed over into these different areas. And the book that I wrote was Groin and Pelvic Pain, oddly enough. And ultimately, the goal is not to have all the answers, because it's an evolving field and we absolutely do not have all the answers yet, but it's really to promote a dialogue and to create a vocabulary that we can all work with. And I think the more we do that, the more we talk across the disciplines between the surgeons and the gynecologists and the PTs and the pelvic floor specialists, I think that this has a much better chance of getting solved and solved well. So I'm very honored to be here. And I think this is really, really important stuff.
It's wonderful to have you. I also want to welcome a physiatrist, Dr. Ahmed, who is a little Instagram famous. Do you want to go ahead and introduce yourself and maybe share a little bit about how valuable your specialty is to people with pelvic pain?
Sure. I am a physiatrist and I evaluate the muscles, joints, nerves of the pelvis. So that's anything between the belly button and the knees. In the field of physiatry, there wasn't real training for pelvic pain, but many times we hear from gynecologists and urologists that there's no source of pain or infectious source. And so as a physiatrist, we're evaluating the musculature and the nerves and the fascia and trying to delineate if there is another cause of the pain that that's often missed. And so, yeah, that's our role.
That's your role. And you see what I like the best. I think the physiatrist can be indispensable, but what I like the best is in some ways you get to play point person because you deal not only with the endometriosis piece, but with the muscles, the bones, the ligaments, and everything else. I try to explain it like you're the quarterback in some ways.
I
Yeah.
had a really good last patient, and she came in. She thought she had, well, she thinks she has endo, and asked if I could do, well, I asked her if I could do an ilioinguinal nerve block today, and her pain went away. And she was getting signed up to do endometriosis surgery. So that was cool diagnostics.
Yeah, we do a clubhouse on Monday. I don't know if you guys have clubhouse yet, but we did like, because I was the host, we did, and we're doing this tonight. We did like 45 minutes on the ilioinguinal nerve, and that the ilioinguinal nerve drives not only pelvic pain, but some bladder pain. Do you want to explain that a little bit, Dr. Ahmed?
Well, a lot of our patients have a little, when their ilioinguinal nerve is compressed or irritated, it can cause some urinary symptoms. So for a lot of patients, we add that injection into our series when we're working on their pelvic floor.
Yeah, it's incredible how much that we all know that's my favorite nerve.
Your favorite.
It's definitely my favorite nerve in the body. If you get a favorite nerve, do you get a favorite nerve? Now, Amanda, you're a pelvic PT. And before we talk to the general surgeon who does a surgical evaluation, when somebody comes to you with pelvic pain, particularly, and you do a lot of hip work because you do a lot of work with athletes. When somebody comes to you, what is the evaluation like?
Sure. So typically on the very first day when we're meeting, I'm spending a lot of time just gathering history. We do that on intake forms, but I always want to hear it direct from the patient because it always sounds differently. I want to get a really solid understanding of their experience, when the symptoms started, what they feel contributes to their pain, what seems to alleviate it. And then I'm going to be looking really thorough at the entire body, really looking at their posture, looking at how their back, their spine is moving. I'm evaluating the hip for range of motion and strength. And then on the first day, I may or may not be doing an internal pelvic floor examination, either via the vaginal opening or the rectum. In some patients with a lot of pain, we may be deferring that, especially if there's been a history of trauma. But that internal pelvic assessment is giving me a better sense of the behavior of the pelvic floor, and I'm looking for possible drivers coming from the muscles. And that may be coming from tender points. It may be coming from poor coordination. So interestingly enough, the pelvic floor muscles are muscles just like everywhere else in the body. They can be strong, they can be weak, they can be tight. And a patient or a person may have good use and good coordination of them, and they may have lost some of that coordination as a product of surgery or as a product of the disease process itself. So I'm measuring their strength. I'm measuring their ability to relax the pelvic floor muscles. I'm comparing the right versus the left and getting a sense of how that patient is tolerating that experience. And then I'm creating a very unique plan of care based off of all of those findings.
And what are telltale signs for you that there's something more going on than the patient just, I don't mean to minimize it, but than endometriosis? Because we typically people with endometriosis like to assume everything is endometriosis. What are some of those signs that something further is going on?
Sure. Usually I'll hear them say that they may have difficulty using a tampon. They may have a history of constipation. They may have difficulty having a pelvic exam or having penetrative intercourse, which tells me that there may be something happening in the pelvic floor muscles themselves, or a sensation of just tightness or a burning sensation that's deep and they can't reach it and they can't stretch it. All of those are subjective or oral reports to me that may indicate something's happening with the pelvic floor. And then when I'm observing them or evaluating them, I'm looking to see, can that patient drop and expand the pelvic floor? Do they have flexibility? And then I'm going to be touching certain areas in the pelvic floor and asking them if it's tender and I'm feeling for a tautness or a banding, I'm feeling for a quiver, areas of restriction in the muscles themselves, just the same way you can get in your neck or your back at a tender point. When you push on it, it zings up and over your head. That same thing can happen in the pelvic floor itself. And that can be a very prominent driver of pelvic pain, and it's super treatable. Those are one way that we can act pretty quickly and effectively, along with behavior changes and overall biofeedback and more exercises for longer term benefit.
So Dr. Zoland, somebody comes in, and this could be a typical situation. They are convinced their pain is being driven by the ovary because maybe they have some endometriosis or a history of endometriosis, but the doctor just wanted them to see you. What are some telltale signs that there are some issues with the nerves going into the legs and the groin that may lead one to believe that that happens to not be pain coming from the ovary?
Right. So knowing where these nerves innervate on the human body is really important. And when you evaluate somebody, you have to start with a really extensive history. When did the pain start? Where does it go? What makes it worse? Do you feel better when you're lying down? Do you feel worse when you're standing up? Is it worse in the morning or is it worse in the evening? You know, all these things as part of the history start to lead one to think that maybe it's not typical endo if it doesn't have to do with the cycle, or at the end of the day, ovary pain, lower abdominal pain could be any kind of pain syndrome that may be irritating one of those pelvic nerves. So an example is your favorite nerve. And by the way, yes, you are allowed to have a favorite nerve. The ilioinguinal nerve can get irritated by an inguinal hernia. And an inguinal hernia is merely just an opening in the lower abdominal wall. And what is there's something that pushes through the opening and can irritate the nerve, just like somebody can have a herniated disc in their back, and that can irritate the nerve that goes down the back of the leg. And the whole point here is to make sure that you're not just assuming that, oh, yes, this is just ovary pain, don't worry about it, or, oh, this is ovary pain, that's all we're going to think about. The whole goal is to think about everything and then sequentially, essentially rule out each of these things. And what I mean by that is you do the physical exam, you feel for hernias, you do a sonogram if you need to, and most importantly, my favorite is doing the MRI for two reasons. The MRI doesn't give radiation like a CT scan does, but it also shows the planes of fatty tissue and muscular structures and fascial structures so that you can really look to see if people have these hernias that we're talking about. An inguinal hernia is the most common, but there are several other hernias that can occur. A femoral hernia can occur, which goes into the leg and can irritate the nerves that go down into the leg. An obturator hernia goes into the pelvic floor, and this can irritate the nerve that goes into the inner leg or down to the knee. And at the end of the day, we want to be able to rule these things out. And if we see that there are a hernia there, i.e. an occult hernia or a hernia that's just not necessarily picked up on physical exam or by even the radiologist, we just want to know whether or not that exists. And then we can evaluate if it does exist, is it the source of pain? And if it is the source of pain, we can go ahead and fix it. There are lots of hernias that exist that are not sources of pain, so we have to be careful about that. But at the end of the day, we need the information. We have to start with a baseline of information about what's going on.
Now, you mentioned something, is that sometimes the radiologist misses these. Sometimes the general surgeon, who's the specialist in your town, misses these. Why is that? And what do you do about that? What do you do about that as a patient?
Right. And it's a great question, and it's a big problem. I think that one of the reasons why the radiologist won't see a hernia that somebody who really is specialized in looking at these is because, number one, they're specifically not looking for hernias. They just get the diagnosis of pelvic pain. So they're looking for the stuff inside the pelvis, whereas the hernias are not really inside the pelvis. They're just outside of the pelvis into the muscular wall. So they're not specifically looking for the hernias, or even worse, they don't have the same definition of what a hernia actually is. So the opening exists, but some fatty tissue is going into the opening, which could easily cause somebody pain. but they're not seeing that as a hernia because it's only fatty tissue. It is not another structure that by definition a radiologist may call a hernia. So unfortunately, it's about a definition of a problem that a surgeon would call a hernia and a radiologist might not. The what to do part of it is a lot more difficult, meaning if you have a report that says no hernia seen, and you think you may have a hernia, or you're not sure what's going on, but as a patient, you have the tools to help educate yourself, get educated. Because if a doctor that you're seeing in your town or in your local area is saying to you, no, we don't see anything like that, but you have come across information that tells you that, you know what, I don't get the sense that they're on the same wavelength as me, you need to look outside of your local area, outside of your local circles. So unfortunately, there's not a huge abundance of people really looking into this, but it's really important to find those people looking into it, because easy diagnoses, or at least diagnoses that we see commonly, all of us that are talking here today, may not be seen by your local people. And if we can make those diagnoses, that may move you along into helping get rid of some pain syndromes. And I think it's important to understand that there's an interplay between the problems that we're talking about. Just perfect example would be somebody with irritable bowel syndrome, let's say, who has chronic constipation. They are a setup for hernias. And unfortunately, because they're a setup for hernias, and yet the hernias may not be diagnosed, you may have a problem on top of a problem that could be solved if it were only seen by somebody. And therefore, it's incumbent upon you, the patient that is, to really look just beyond your local circles. If you don't feel like the doctors and the radiologists are really knowing what they're looking at necessarily, or really looking at your specific problem.
Yeah, I think that just like constipation may predispose you, and we don't always see eye to eye on this, but I think that the endometriosis itself, like having a frozen pelvis, your pelvis is frozen, but your body is still moving. And I think that in its own way predisposes you to getting them. I've spoken extensively with Maurice Chung about this, and he actually says, it has a lot to do with the way they put the trocars in, or minimally invasive surgery is fantastic because we get up and moving faster, but maybe there's some sort of weakness that's contributing to that. He actually now includes certain nerve blocks in his protocol. But we're here tonight and we're talking about I could talk about hernia until February when the Endometriosis Summit comes. But I wonder, Dr. Ahmed, someone comes into your office, and we see this a lot. They bought a cane off of Amazon, which drives me crazy because it's so bad for bone development. And they're in pain and they need help. What are the choices of things on the long list that could be contributing to their pain? You didn't know it was going to be like a quiz tonight.
Wait, so the patient is an endo patient, or just
Well,
a patient
it's an endo patient, and they have ongoing like leg pain, groin pain, hip pain, because we talk about hernia because I have that focus, but there's a lot of things that could be going on. Yeah.
So I mean, obviously the first thing we do is we examine the patient. We want to make sure that it's not their hip, or is it their hip, or is it in their groin? Because a lot of patients get confused because they have no idea where their actual hip is. And then we kind of show them the difference between like where the actual joint is versus where the ASIS, or what they think is their hip. And then we potentially order imaging. So we want to see whether they have a labral tear, whether there's an impingement in their hip, or whether they have a hernia. And then I quickly ask Dr. Zoland to take a quick look at it and tell me if he thinks there's a hernia there or not. Or if a patient wants to diagnostically do an injection, we can tell right away whether there is something there or not. But in terms of addressing the pelvic floor and addressing the potential hip, we use suppositories on our patients. We do medical management on our patients. We do nerve blocks, trigger point injections on patients, depending on if they need a referral to an orthopedic surgeon to evaluate the hip, or a referral to Dr. Zoland or someone, or an endosurgeon to see if they've never had it, like a definitive diagnosis of endometriosis, just to talk it through and see what the possible causes could be, before jumping into any single surgery. And then if I'm lucky, I can try to get a combo surgery out of some of them.
Sometimes they're very picky about that combo surgery. And they like to maybe blame the physical therapist who has dragged them together to do that. I wonder, Amanda, you teach a lot in terms of hip and running and leg pain. Can you tell everybody what FAI is?
Sure. Yes. So FAI is femoral acetabular impingement syndrome. It is often a very difficult issue to diagnose. It often involves a lot of different types of practitioners, including imaging and physical therapy, and a surgeon who's highly, highly specialized in hip. And so what happens is usually there's poor alignment of the head of the femur in its socket, and it can cause changes to the labrum, which is this nice cushion that surrounds the acetabulum here. Well, actually here. Right in here. It's poor alignment between these two bony structures, which over time can grate and become inflamed. It can result in growth of new bone where it should not be. A person may report catching, locking, pain, or a sense of giving way. And so when that person comes in, they may be experiencing deep hip pain. They may be hearing a little pop or a click. And certainly when I'm doing my examination of them, I'm listening for that. There's a couple of provocative tests, which are tests that we do to see if we can replicate the symptoms that we're hearing from the patient when they're on the table. And so I would do that. But all in all, it does take examining the patient and listening to them for these different symptoms, and then getting the necessary imaging. Sometimes a physician will want to intervene and do a surgery on that, and sometimes they'll recommend that we try to be as conservative as possible, which would mean getting to work with physical therapy and trying to ensure that they're able to do the things that they want to do. Oftentimes with runners, it can be preventing them from being able to run, and it can get to the point where people can't get up and down stairs or get in and out of their vehicle, and it gets in the way of their activities of daily living. And then we do recommend intervention, and then it's a very prescribed rehabilitation process afterwards. But the interesting thing about FAI is that the pelvic floor is right on the other side of that hip joint, and so it's necessary to examine those deep pelvic floor muscles. But oftentimes, as a result of these issues, the pelvic floor will clench and guard because it is very painful, and we will, on internal examination, find tender points or restriction in those pelvic floor muscles on the side there as a byproduct of that hip being needed to be guarded against and stabilized from these smaller muscles, and then also the muscles on the back side of the hip too. So often they do go hand in hand, and we do want to manage the pelvic floor while we're determining what the next action is going to be for the joint itself.
Right. So I read an interesting study this afternoon on FAI. And if you think that endometriosis is misdiagnosed, it is. But FAI, not such a great road for people either. So on average, it takes 3 years to diagnose. People have seen typically 4 providers or more. And what I didn't love, which is one of the reasons why we come and do something like this tonight, 15% of people have sort of the wrong surgery and the wrong surgeon doing the FAI surgery. And they've had that surgery for another location in the body other than the hip that was supposed to fix their hip pain. And then what I thought was interesting was that with FAI, the statistics read that 67% have lateral hip pain, right? And so we can see that in endo too with sidewall endometriosis. 88% have groin pain, which we're all like in this foursome groin pain experts at this point. And 37% have anterior thigh pain. So let's discuss, because there's a lot of crossover between groin pain and anterior thigh pain. And So let's start with you, Dr. Ahmed. How do you tell the difference between hip and groin? And how do you explain it to a patient? How do you tell whether the pain is coming from the hip or the pain is coming from the groin?
So when you move the hip in different rotations, internal or external rotation, if a patient is able to have some reproduction of their pain, so a lot of people think their hip is much higher up because they just touch the part, the bony part of their pelvis that's along the belly button, like going all the way to your left and your right. That's your ASIS. A lot of people just think that's their hip. And so they are describing the area where their nerves are traveling. In their actual hip, it's actually further down a little bit over the anterior thigh. So for patients, depending on how diagnostic they want to be, we could, potentially do lidocaine or like a injection into their actual joint to see if they get any pain relief when they do that. When they typically do these MRIs for their hips, they often have an injection in that same spot to get put contrast through so they can see where their actual hip joint is and see if there is an actual tear, and it gets a better picture with that MRI. Was that the question? Is there anything else?
Yeah, well, that was awesome. So I wonder, Dr. Zoland, differentiating between, is it coming from the hip or is it coming from the groin, which probably is 50% of your day?
Absolutely. It's very, very common that I'm asking the question, chicken or egg. Is it hip driving groin pain, or is it groin pain as a primary generator, and then maybe driving some hip pain? And I think a lot of it has to do, going back to this point of taking a really extensive history and knowing what causes pain for people. If people are sitting and they're in pain just by sitting with their leg at 90 degrees, to me, I'm starting to think more hip than groin. If they have a configuration of pain that they're describing as they're walking and the pain's getting worse, it's crescendoing, it's starting just at the top of the thigh in the middle and then wrapping around the outside to the buttock or the lower back. We call that like a C shape around their joint. That's hip pain until proven otherwise. On the exam, when I'm examining them for groin pain, do I not have any hip symptoms? Do I have no history that's related to hip? And yet they have pain when they're doing a sit-up, and those rectus muscles that pull the body upward are pulling on the pubic bone, which is sort of just off the center, that bony structure at kind of that right in the groin at the front. If you draw a line down from your belly button, I'm trying to do this for lay people, from your belly button straight down towards, your genitalia, just off to the side where that bony structure is, there may be pain right there. And if that's the only thing somebody's feeling, and then the pain goes down into their inner thigh, that ropey tendon on the inside of the leg is the adductor tendon. Is it going down into that tendon? Then maybe that's primary groin pain. So when I'm looking for somebody to figure out if they're having groin pain as a result of a hip problem or a primary problem that they have some tears into the attachments to the groin, it's really important for me to ask all these questions and do all these things on the exam. And I think, I think the other points that Amanda was making, that Dr. Ahmed were making, is simply that, all of these things play off of each other. So the perfect example is that if you have a hip problem and there's some instability, meaning that the joint is not perfectly in position when people are trying to move and to walk, that's going to put a lot of pressure on the musculature around the hip to hold it in a better position, which is fine. That's what the muscles are doing at that moment, but that's not what they're made for. So they get tired and things start to ache. So people start thinking, oh, I have this muscle problem or this attachment problem to the structures at my groin. And yet the problem is more generating and starting from the hip. And it's the same thing with the pelvic floor. When you have an unstable hip, your pelvic floor muscles in the same way will hold that hip in position. And those muscles can get fatigued and those muscles can start to hurt. And then you can start developing some pelvic floor symptoms. So there's a lot of overlap that goes on with all of these things, unfortunately, it makes it A, very, very difficult to tease out, and B, sometimes you don't know which one's the chicken or the egg. But for us, this is what we do a lot of the time. And sometimes it really just comes down to these diagnostic injections that people are talking about. It comes down to the radiology. Do we see some real bad pathology going on in the hip, or some subtle pathology for that point, or for that matter? Do we see hernias? Do we see a detachment of the pubis? That's why ultimately you've got to go with the history first, get a really detailed history plus an extremely detailed physical exam, and then go to your diagnostic testing. But you have to go to these places that know what they're doing, how to run the tests, and have people who especially know how to read the testing. So all these things are interplayed with each other.
Definitely. And you throw some endometriosis in there and right. What do you do? So I wonder, our second discussion, because we have this great panel, the labrum, cause of pain or not cause of pain. We'll start with you, Amanda.
Certainly it can be a driver if, again, it's getting involvement from the pelvic floor. I think too, anytime we're talking about labrum pain, we got to look at the why. Labrums don't just degenerate on their own. So again, it's going to be often due to excessive wear and tear on one side versus the other, unless they're both having it on those sides. So when we're looking at a person that seems to be experiencing that with a popping, clicking, locking, when we're trying to examine it, other drivers can be impingement on the local nerves and also pulling in the muscular involvement as well. So from that perspective, we want to be addressing all of the pelvic floor symptoms. We want to be strengthening the hip in the back and on the side, avoiding leg crossing, avoiding shearing, and helping them to better understand how to stabilize on that side. And then again, looking at possibly intervening, because again, that's one where sometimes it's important to be conservative and stay with the physical therapy route. But if the patient's not improving, certainly we want to be considering the possibility of surgery. And again, working with somebody who does labrums or does FAI almost exclusively. It's not enough to just be a hip specialist from any medical standpoint when we're dealing with those diagnostics. When you're looking at the person performing the procedure, we want them to be having high reps and be highly skilled in that. And to speak to what you were saying about having the wrong procedure, or having the surgeon having it not have been a successful outcome. And there's a lot of things that could lead to that. But I, for example, will send people 5 hours away from me to get that particular procedure done, because that's where I know that the skilled person is that will do it and it's worth it. So.
Right. Now, Dr. Ahmed, labrum, generator of pain or not? Because I have my own opinion on the labrum.
I think you'll, I don't know if you'll agree, but there's a lot of incidental labral tear findings that don't actually amount to anything. I don't know if we imaged every single patient, how many of them would have a labral tear that could be really partial, non-displaced, and but patients are kind of compensating in their own way. So whether they have a labral tear or not, they could still have pain in their hip. I mean, obviously patients with endo have a ton of pain. It's usually, I mean, it's not necessarily unilateral, but if it is unilateral, sometimes they're compensating on that side. What?
No, someone asked a very good question. I'm like, can't wait. Sorry.
Okay. So for a lot of people, that compensation and that compensatory, the way that you're standing and grimacing on one side every time they stand on that side of their hip, that can cause pain, but that doesn't necessarily mean the labral tear is the chicken. It might be the egg, depending on which way you're looking at it. Really quickly, we didn't talk about the pudendal nerve when we were talking about the nerves, and I think Dr. Zoland and I are always talking about, is the pudendal nerve another cause? Because with a lot of our patients, that nerve, innervates the pelvic floor, and it can also be another confusing nerve for patients who have pain that doesn't necessarily go away with like an ilioinguinal nerve block or a genitofemoral nerve block. And, that's also like the pelvic floor being the chicken or the egg, and the pudendal nerve, which causes a lot of pain with sitting as well.
We have to have a whole pudendal nerve night, I think, because I got a lot of questions to Yaniv. Dr. Lariche was on last week. And, you know, he could talk about pudendal from a whole different spinal perspective. And I had a vein doctor contact me on Instagram who wanted to talk about the veins surrounding the pudendal nerve and how they actually generate a pudendal nerve like pain. And now you brought it up. So we have to have a whole pudendal nerve night. Plus Tracy Sure is a faculty member and she'll never miss an opportunity to talk about the pudendal nerve. I was talking about the labrum, and I think, you know, 3 of us practice in the same geographic area. And I sometimes think the labrum is the hot diagnosis of the times. And there are people who genuinely have labral issues, and I'm not negating that, but I think it's like the thing like, oh, I happen to shove you in an MRI machine and look at what I found, which doesn't necessarily mean that that's the source of your pain. And then it becomes, because we're going to have the Words Matter workshop at Endometriosis Summit, then it becomes, we told that person that they had a labrum tear. So now there's that whole mind-body connection to, I have a labral tear, I'm backed into this corner of, I have to behave like a person who has a labral tear. And it's not really the source of the pain. And I've seen, I work virtually now, and I see, and I go over, I show diagrams of all this stuff, but I see it at least 2 or 3 times a month that somebody's had that labrum repaired, and the pain is being generated by endometriosis, or the pain is being generated by the hernia no one decided to find. And I think we all at some point past 40 have labral tears. You're nodding a lot, Amanda. Do you agree a little bit?
Yeah, definitely. Yeah, I definitely do. I mean, to both your point, if we image people, it's the same thing with the herniated discs and kind of looking for a reason, or you know, the possible driver. So it's, you know, for example, I would only refer out for imaging or a consult with a surgeon if it was like a very audible pop and click that when I was doing the provocative test was eliciting that pain response as well, and still working on addressing all the other conservative things too. But I wouldn't even consider the referral unless I had done all the conservative things first.
Yeah, so I wonder, you know, we have a question about it, but I was going to bring it up anyway. Dr. Zoland, lots of people in the endometriosis community have that pain before surgery. They need an excision, so they go through an excision for the disease. They come out of surgery with the pain and they say, I can't have a hernia. My doctor says it's not there. He looked and there was nothing there. Why could that be? He knows I have my own answer, but why could that be? And is it really an appropriate expectation? I always say the endometriosis surgeon is not going to find it, and we shouldn't have that expectation of them because they're not hernia specialists.
Right. Well, I mean, 2 things. One is that an endometriosis surgeon may know exactly what to look for, but when you're inside of the abdomen with a scope, and a scope being the tool that you use to look around, you may not see that there's a hernia there because they're looking for an opening where something's pushing through. But when you're inside of the abdominal cavity, you may just see the wall, meaning the peritoneal lining, and that might not be pushing through, but some fatty tissue in front of that is pushing through. So you may be looking at one layer and you may not see the hernia, but deeper down beyond where you can see, there might be one. So number one, the best way to diagnose a hernia is with the imaging studies that we were talking about. If there's small hernias going into the leg or into the pelvis that you really can't see on physical exam. And then number 2, the endometriosis surgeon may not, and I know I'm going to get a lot of flack for this, but may not know exactly where to look for these particular types of hernias. So if an endosurgeon says, I didn't see a hernia, it doesn't mean that a hernia does not exist. But, you know, it's changing a little bit. I mean, I was just sent a patient from one of the endosurgeons that, you know, we all know and love, and he specifically saw that there was, from the inside, a defect in the abdominal wall that he could see an opening where the hernia existed. So 2 things to that. Number 1, he was looking in a spot to be able to recognize it because he knew to look there. And then the second part of that is this hernia was big enough that the opening allowed an indentation of the peritoneum so that he can actually make that call. So ultimately, an endosurgeon should never say to a patient, I didn't see a hernia, therefore you do not have one. That is not a correct statement unless the appropriate imaging was done after they made that statement, or at some point along the line of the patient's history was the imaging done to look for these specific hernias.
Yeah, I mean, we're here to stir up trouble. None of us are status quo type of people. We're not here to, go along with the story, I feel like. And I do feel like even the best endometriosis surgeons in the world, who we love, I'm not saying anything bad about them, it's just not something they can view at the time of surgery. And by the way, the same goes for radiologists, and the same goes maybe for the general surgeon in your area. And so if you don't have somebody that's specializing in this or that knows what to look for, you may have to go elsewhere. We've said that a few times. And I think, but I have seen really blatant hernias. I saw this summer the fallopian tube pulled through a hernia. And we were in there on an endometriosis surgery, and there was no endometriosis, but there was this great big hernia. And that was the source of we think their infertility, right? So which is unusual. And we think of hernias and infertility in men, but we don't always think of hernia and infertility in women. So when Amanda had the pelvis up, and I just moved, so I haven't unpacked my pelvis, right? I wonder, Dr. Zoland, if you could talk a little bit about the obturator hernia, because I'm sure Dr. Ahmed sees this all the time. And as pelvic floor PTs, not all of us understand that it's not the big, scary hernia that you Google that kills old ladies, that an obturator hernia is something different. Do you want to explain what it could do?
Sure. So the obturator hernia, when we're looking at that bowl of the pelvis, and if this is the front of the body and the belly button's up here, the obturator hernia is deep down going into the leg. And that obturator hernia is a little opening where the obturator nerve and artery and vein go through. And sometimes the opening can expand and allow other things to go into it. And the classic example that everybody looks up and, to your point, gets scared about is that, oh, I have a 70-year-old lady hernia and there's a high death rate with that hernia. So I have 25-year-old men calling me and saying, I can't believe you told me I have an obturator hernia. Am I going to die like that 70-year-old lady in Wikipedia? And the simple fact is that no, 99.9% of these obturator hernias are a little bit of fatty tissue going into the opening. And 99 times out of 100, there's no issue with that. Quite frankly, you can leave most of these things alone. However, they could cause some pain. And the big point here is that it's the same kind of pain that could be described as hip pain. It could be described as endometriosis pain, and it could be described as, any of these topics that we've been talking about tonight. So the key point is that we're looking to make sure that we don't miss this as a diagnosis. And the little obturator hernia that might be going into that opening down in the leg can be hitting the nerve. That nerve is a motor nerve and a sensory nerve. Motor meaning it causes muscle contraction, and sensory meaning it gives you sensation at the skin level. And that nerve is the inner thigh and the muscles to the inner thigh that pull the legs together. So if there's an obturator hernia pushing on that nerve, you can have pain and you can have motor dysfunction. And that's why, because it's misunderstood by even the emergency room docs that you may go to trying to figure out if you have an obturator hernia or not, are not even going to know where the obturator canal is or where the obturator hernia is. The other point here is that the obturator hernia is one of the hernias that go into the pelvic floor. So if you have a pelvic floor problem, and let's say along with the pelvic floor problem, you have chronic constipation, and ultimately because of the chronic constipation, and the reason why chronic constipation is a big deal is because it increases intra-abdominal pressure, which increases the likelihood of a hernia. So you see how these things domino effect. And at the end of the day, the reality is that, these things, these obturator hernias or any other occult hernias that are not necessarily being called can be a result of other syndromes that people have. And then you have to keep looking for the other realities. The reality being that an obturator hernia could be something going into the leg causing leg pain. Unfortunately, I've seen people who have the hip replacements, the pain didn't go away, and it turns out that they had an obturator hernia. And you fix the obturator hernia and that inner groin, hip pain goes away. But the reality is, if it's not thought about, it's never going to be looked at to be seen if it's found or to be found.
Certainly. And I tell all the pelvic PTs, I just did a virtual mentorship, and the case she brought me was the person is not moving forward with their pelvic floor. And when we go through the case, in my mind, it became very clear she had an obturator hernia. But then I have to think of a creative way to say it, because if I say obturator hernia, they're going to put it into Google and think they're dying, which is very funny because I used to take care of my mother and I would never let her push, because I'd be like, you'll be that old lady in the ER. Like, that's how many times I listened to the Google, or I read that in Google. But I think, you know, we don't think of that as pelvic PTs. Like, we're trained in the hip. I even believe, and I haven't gotten a chance to ask that, we're trained in the knee and the foot causing that groin pain, right? But we aren't trained to think this could be the obturator. And we do the obturator muscle, but that obturator hernia is there more times than you think. So we have some questions. This is a great one for Dr. Ahmed in some ways, because this is a patient you would see. They have an excision and they didn't have any of these symptoms till after the excision. So, I mean, what do you think, like, what do you think of that?
They have a hernia symptom?
Well, they have all the hernia symptoms, but it didn't happen till after their excision.
So, I mean, obviously, when people have multiple pain generators, sometimes they can't recognize that it's different things. And so, you know, it's not unheard of that a patient will have the endometriosis excision, a certain type of pain goes away, and then suddenly they have one specific point tenderness or point pain that's still bothering them when they do certain activities. And that's when we diagnostically try to figure out, is that something else, or is it scar tissue? What is it? Are there adhesions? We can do injections, figure it out, and then send them off to have that repair if there is a hernia. You know, it's interesting. Dr. Zoland and I was telling him last week, we had a patient who had a urachal remnant, and I wanted to ask you, Sallie, if you've been seeing more of that. Well,
yeah. First of all, I had one, which was blamed for years on end, that was not the source of pain. But I see those, and I go back to, if you ever watch Redwine's video on YouTube about embryological development and endometriosis, I think about that urachal ligament, or that remnant that's left behind. And is there something that goes on in development that is contributing to this sort of like connective tissue experience? And of course, we're doing connective tissue workshop at Endo Summit workshop. So I'm doing a lot of research on that. And I have seen that it typically causes, it'll cause some bladder issues, and it'll cause some belly button issues. And I have seen it a few times because somebody decided I was like the expert on this at one point in my career, sort of pull in for some reason or another to the round ligament. And my go-to technique really would be the visceral manipulation. I have seen surgeons who do a full peritonectomy. They usually, depending on your age, but they'll do it as part of your endometriosis surgery, and the person still gets no relief. Do you see, Amanda, do you do any visceral work? I don't remember. Yeah.
Yeah, I do. I do a lot.
Yeah.
And I do love the urachus mobilization. I think a lot of people do have tenderness around that area, even if it's not the remnant. Sometimes there can be adhesions that build up around the ligaments. And I get a lot of great reports after the manual therapy.
And I see also, I don't have any proof of this, but I I think when they put everything in to do the surgery, they do move the organs just like a little bit in a good way. I mean, they're not like being malintention. And I do see that people have that pain after surgery. And I think that's because it's put some sort of tension between the bladder and the belly button. And I see heartburn with it, which is very interesting because the person who treated me, she's coming to Florida for 6 weeks, and I like can't wait to see Marianne Ryan's on her way down. Can't wait, because gonna shove my belly button in front of her. But I see that, and I have seen it also resolve with pregnancy, which is not an endometriosis thing. It's because the abdomen's expanding, and I think it expands that. Yeah, maybe too much information. Was that so? We have Amanda, do you see any connection between hip and pelvic floor to rectal pain?
Yeah, certainly can, especially because, I mean, interestingly, a lot of the hip muscles that we think of as being only hip muscles share a fascial plane, which is like a thin tent wall between those and the pelvic floor themselves. So the back fibers of the pelvic floor attaching into the tailbone and going around the rectum here can sometimes be pulled more significantly on one side versus the other if we have another injury or driver to the hip on that side, again, because of the guarding or possible joint restriction itself. And that can lead to changes, and that can lead to a trouble with relaxing and dropping to be able to have a bowel movement. Sometimes it can also be placing undue pressure around the nerves that surround, it's a very sensitive area around the sphincters and around the deeper pelvic floor muscles too.
Very, very interesting. You know, it's all just so connected. Now we have a question about Allen Masters windows. I feel like, and then I have a question for the team after, but I'm going to take a stab at that one because Dr. Vidali doesn't like to join us on Mondays anymore. So Allen Masters window syndrome, or is this defect that you get peritoneal pockets. And the significance in endometriosis of the defect is that there, you have to sort of go into the pocket, almost like I always say reverse the suction cup. So make it pop to the different direction when you're the surgeon, and make sure there's no endometriosis inside that pocket. Now, with the window itself, somebody is asking me, how does that relate to hernia and things like this? So Allen Masters can be from screwy, unpleasant connective tissue, right? I think we never did a study, but you don't have to have EDS to have connective tissue issues. I'm definitely in that category, much to everybody's dismay. And so the Allen Masters window, if it's sitting above a nerve, you're going to open that connective tissue oftentimes above a nerve in the pelvis, and you can get the free fluid that's in the pelvis from the endometriosis sort of trapped between the window and the nerve. It is not uncommon to see this with endometriosis. However, as my career has gone on, what we used to just think is the Allen Masters window, I have seen in those patients tons of hernias, right? So because it's a connective tissue defect. And I think one thing happens is connective tissue isn't that great, and people with endometriosis are great, and we go through the world and keep moving no matter what, and things sort of, you know, get compressed and have issues. But the other piece I go back to is that the endometriosis surgeon knows you have pain. They've done a thorough evaluation if they're an excisionist, and they go in and they see the Allen Masters window and they think, what, that's it, that's your source of pain. But they've never sort of backed up and looked at what's compressing and pressing against the nerve. And was it that this was already there, or and they didn't know, you know, you don't know what you don't know, and we don't have an expectation of that, and that it wasn't the Allen Masters window causing pain, but yet the undiagnosed nerve issue. Does anyone else want to comment on that? Does anyone else know what an Allen Masters window is, or do I have to explain it a little better? So we had a question on Clubhouse today, and I did my best to explain it. But we had a question about iliohypogastric nerve pain. So either Dr. Ahmed or Dr. Zoland, do you want to talk a little bit about what could be some of the symptoms of iliohypogastric nerve pain? Go ahead.
I'll take this take. So the iliohypogastric nerve covers the area from the belly button downwards towards the groin crease. It doesn't go all the way towards the groin crease or to the groin crease, but it covers that area. And essentially it's paired oftentimes with the ilioinguinal nerve, which covers just a little bit lower than what the iliohypogastric nerve covers. And a hernia an inguinal hernia can still irritate both of those nerves. And the pain would be essentially wrapping around from that iliac crest, meaning the pelvis all the way at the side of the body, wrapping around towards the front, towards the belly button, and anywhere just below that. So that would be the iliohypogastric nerve distribution. And then sometimes when you have something irritating that nerve, and it could be a whole host of different things. There could be just a little benign fatty tumor called a lipoma irritating the nerve. Could be a hernia, could be a nerve entrapment syndrome from some scarring from some kind of injury in the past. The pain would be where we described it, but it also could be going backwards, following the track of the nerve around the body towards the back as well. So oftentimes when you fix people's hernias that's irritating the iliohypogastric or the ilioinguinal nerve, a lot of times the hip pain that they thought was just part of a hip problem may go away because that's where the nerve is coming and wrapping around from.
Yeah, very, very interesting. We have a question about abdominal wall. We used to call them trigger points, but tension points in the abdominal wall. Amanda, how do you treat those and what do you think might cause them?
Drivers can be posture. So when we're in pain, oftentimes we try to shorten on our own to protect the area that feels tender, and that can result in shortening of those muscles. Overuse in some cases where you're using one side of your body more than the other. Really common with endo is for people to be a little bit slunched over, trying to guard and protect the pelvic organs. The way that I treat it is I usually start with very gentle manual therapy, skin rolling to the superficial aspect of the abdomen. And then depending on the patient, I may do more of a strain counter strain where I'm applying really gentle tissue and then shortening around it. Usually I'll gently pull down the rib cage itself, or I may also do some cupping. So using really small cups, and I do kind of an active cupping. So I won't just put the cup on and leave it. I'll drag it around and do more of like a myofascial release in that way. And then I'll be giving them some stretches to do as well at home to help make sure that we're moving out of that posture and getting really good active range of motion with the rest of the trunk.
Yeah, I think that is one of the examples of surgery. You're definitely clenching post-op because you're up and moving so quickly. And that's why we like to see everybody who has surgery see a pelvic physical therapist, because they're going to work your abdomen pretty well. So before we do our giveaway, our crowd here on Zoom, if you live in the continental US, and you don't have to tell me where, but if you live in the continental US, you can put your little Zoom hand up and I will pick my winner from that. But I want to ask everybody, all four of us, are faculty at this year's Endometriosis Summit. The Endometriosis Summit is February 18th through the 20th. It is available both in person in Orlando, Florida, and online virtually. We're building out a different virtual platform than last year, but we're building out all these extras for the virtual platform because we're prepared. Thank you, Omicron. And I just want to know, we'll start with you, Amanda. What are you excited to see at the Endometriosis Summit?
I'm excited to see my people. I'm just so looking forward to seeing everyone again. I'm excited to be talking about what's the latest in management. I'm excited to be talking about how to better manage pain symptoms, but I'm excited to see all of you. I've got my plane ticket, I'm ready to go.
That, I haven't seen the facility where we're having it yet. So I can drive there from here. So I hope to drive there at some point in January, but I miss people too. I mean, try having the worst year of your life and you don't get to see any people. Right. Dr. Ahmed, you are joining us as well. You're going to do a panel, and also, I'm not sure you're aware of this, but Dr. Shrikandi is doing a masterclass in the pelvic nerves, and you're supposed to be a part of that. So, and that's a lab for physical therapists. First time we ever offered a lab for physical therapists. Dr. Ahmed, what are you looking forward to in terms of the Endometriosis Summit?
I'm also excited to see people in person, because I'm really, really, really hoping that we can all come in February and this Omicron doesn't cancel any plans as much as it already has. I'm excited to hear, I think Iris is coming and Dr. Larish will be there. So I'm excited to see some old friends and new ones.
So I think it should be really exciting. We're having Linda Bluestein, who's the hypermobility MD. And I think in general, we don't get enough training in connective tissue disorders. And so she's doing a workshop. It should be really, really good. And there were some questions about EDS and hernia. And I have to say, I'm going to save them for when we have her, because connective tissue and hernia is a whole different world. As most of you, as our panel knows. So Dr. Zoland, you will be joining us for the Endometriosis Summit. What are you looking forward to?
I'm just looking forward to the discussion. I think for me, each year the discussion expands, and it just keeps adding more and more pieces of information. And I think it's incredibly it's just amazing to see like-minded people trying to solve really difficult problems. And again, we don't have all the answers, but you're not going to get all the answers unless you have these really open, honest, fully detailed types of discussions. And honestly, this is all you, Sallie. Huge kudos to you for bringing these people together. It's a grand pain in the ass to do it, and I know that, but this is the only way you're going to get just amazingly good thought processes and discussion, and that's the only way you're going to get a really good forward motion to this really difficult problem in general.
Right, we'll have to see if we can have you log in. Dr. Rakuya is running this surgical boardroom. And so, which is for surgeons, very, very interesting. And what the surgeons will do is they'll put up a video and they'll stop it and they'll say, this is what I did step 1. And then they'll open it to the room of other doctors and they'll say, what should be step 2? What could I have done? What could I not? And it's a very open, that's our point, an open conversation to move everything forward, not to pit people against each other, but to say, this is what I saw. What would be the direction? How would you hold your tool? What would you look at? Actually, that case with the fallopian tube through the hernia might be a good one. But so that's going to go on. That's new this year. And then the other thing is, because Dr. Mauricio Abreu is our keynote, we have a whole South American contingent, and they don't get as much of this pelvic pain education that we have. So it's a great way for our physical therapists and our nutritionists and everybody to expose whole new endometriosis treaters, right? It's really amazing. Okay, so winning the prize tonight before we sign off is Amy Miller. Amy, you're going to have to DM me or put your address specifically to me in a chat, or if you can't connect me, you can reach out through the Endometriosis Summit website. So the last thing that I want to say is tickets are on sale. There is going to be a price increase in January. You are available virtual and in person. We do have a limited number of virtual scholarships. I would suggest purchasing your tickets before they are gone, especially for Endo Summit workshop. So you can reach those tickets at www.theendometriosissummit.com. And we'll see. I don't have a topic picked for next week, so we may be back here talking about pudendal again, but we will see. And I will see everybody soon. Much thanks to Amanda and Intimate Rose for the giveaways. I do want to remind you that Intimate Rose sells a whole lot of pelvic products that may be helpful to you, and we have codes if you need a discount, and we can talk about that. Dr. Zoland has his book available on Amazon, and we all know I come to Florida for the winter, but I'm very upset because I left the book at home.
I got mine. I can get it.
No, wait, but the book is just the right height to get the camera. And I'm like running around the house.
What
I'm
we
like,
were going for, yeah.
I don't know what to put under the computer to get the camera the right height, because it's like, I have like the stand, but the stand I need just like a little bit. I know. I don't know. So also, let's talk about how to reach everybody. Dr. Ahmed, how can people reach you?
At pelvic rehabilitation, that is pelvicrehabilitation.com. It's our website, and you can for scheduling an appointment, or at Dr. Ahmed, AHMED on Instagram.
Yes.
And Amanda, how can people reach you?
At intimaterose.com, or by emailing support@intimaterose.com, and then on Instagram as well under the same name.
Excellent. And Dr. Zoland, how can people reach you? I bet you don't know your Instagram.
I may not know my Instagram. coresurgicalmd.com. Just Google my name. I'm out there. You can find me. And Sallie, you may know my Instagram.
Right. So he's at Dr. Mark Zoland on Instagram. And do all of you work a little bit virtually?
A weensy bit.
Yeah.
Yeah.
Excellent. All right. So thank you. And go ahead. You guys are going to log off. I have to get Amy Miller's address because she's our prize winner.
Yay. Congratulations, Amy.
Take care. Good night,
Good
everybody.
to see everyone.